Hi everyone, welcome to ResearchMD.com. We have another great presentation today. We've been doing series of lectures on endocrinology. Today our topic is RIEDEL thyroiditis. Before we go, let me introduce myself. My name is Dr. Pramil Cheriyath. I'm a program director in internal medicine residency and the transitional residency in the United States, and I teach medical students and medical residents on a regular basis. I'm also associate professor of medicine to large medical schools. Okay, now let's get into our main topic today is the RIEDEL thyroiditis. First of all, first thing you have to do is define what is RIEDEL thyroiditis. You got inflammatory, infiltrative, fibrous, sclerotic condition, a lot of fibrosis, okay, that lead to progressive destruction of thyroid gland. Not only it destroys the thyroid gland, it kind of starting to affect the adjacent organs also, and then it can cause compressive symptoms, endocrine abnormalities, as the fibrosis can even cause to the airways. It can go to the parathyroid gland, and it can go to the other local structures. So the main point is happening is lots and lots of fibrosis. Now, what are the other names you need to know? And the main thing you have to know that it can also called woody thyroiditis because of the feeling of the woody when you feel and it can be like a fibrous thyroiditis, RIEDEL invasive thyroiditis, and stroma fibrosa. Those are the other terms we need to consider. Now, epidemiology, if you look at it, females 4 times more likely. Okay, all the thyroid disease, most of the females unfortunately are high risk. And the age group is between 30 to 50. Now let's look at the risk factors. This is not very clear, but smoking clearly associated with the EB virus, and the other one also we need to know. Okay, now let's look at the associate conditions also, very, very important. Again, systemic fibrosis, 38% of the people can have other systemic fibrosis, very important. You can have associated fibrosclerotic process, and you can have salivary gland involvement, lacrimal gland, lymph node, ophthalmic and orbital lesions, and you can lung, pleura, mediastinum, kidney, all of these organs could be affected. The other thing is you can have retroperitoneal fibrosis. That's another examination question, because be careful. Somebody writing a question about RIEDEL thyroiditis, they can always put this retroperitoneal fibrosis, okay? And then we talk about the chronic pancreatitis, sclerosing cholangitis associated with it, and fibrosing mediastinitis also, we talked about it, that's associated with it, okay? Now, the clinical presentation, what is the first thing we have to look at it? We have to look at the thyroid gland, right? That's the first thing we have to look at. How to say hard fixed mass, kind of like the woody feeling, that's why we call it woody thyroiditis, that the definition for that, okay? And then once you look at the thyroid, what are the other? We talk about this fibrosis, compressive symptoms, the other organ. Trachea can affect, and you can esophageal trachea when it compresses. You can have dysphagia, you can have shortness of breath, and then esophageal, again, dysphagia, you can have recurrent laryngeal nerve, coughing, and then there's something called Tolosa-Hunt syndrome. What happens is the inflammation behind the eye, and that can cause ophthalmoplegia kind of symptoms. And then you can Horner syndrome, cerebral venous thrombosis, because cerebral veins can compress. And finally, you can also have hypothyroidism symptoms, which you already know, like fatigue, cold intolerance. All of the symptoms are very important, okay? Now, let's look at the pathophysiology. That's the next thing we have to know about. What is the main thing, pathophysiology? There's autoimmunity, immunity, and allergy background also, okay? So you got predominantly the response is T helper 2 cell. That's what we need to know, okay? Now, we look at over here. There is T regulatory cells that activate TGF beta cells, okay, and that cause fibroblasts, leading to fibrosis. That's the main pathognomonic process kind of going on, fibrosis. And then you can have IL-21 get activated, you can have germinal center with the lymphocytic infiltration, then you can IL-5 that can also cause eosinophil mast cell that can cause increased IgE cells, and then IL-4 activation lead to macrophages. Then it also, this Th2 helper cell can formation of plasmablasts activate the beta cell, activate the B cell, not activate the B cells. And what does it do? The more plasma cell production, which is increased to IgG4, okay? IgG4 is the least common immunoglobulin produced in the body, but in this case, IgG4 level goes up. Because of this eosinophil and mast cells, IgE levels can go up, and the main pathophysiology. Now, let's say if you do like a biopsy of this lesion of the thyroid gland, what do they usually find? Dense lymphoplasmacytic infiltrates. You can have storiform type fibrosis, which is the world pattern, okay? Then you can have obliterative phlebitis also we can have in this patient, okay? Remember that. Now, let's look at our diagnostic criteria. What is the diagnostic criteria? You got it's an IgG4 related disease, right? If there is mass greater than one organ, okay, and then serum IgG4 level 1.35 gram per liter, and then you got plasma cell and lymphocytic invasion greater than 10 IgG4 positive plasma cells in the high power field. Okay, remember that this criteria is very important for the diagnostic. Now, what labs? None of these labs are like diagnostic kind of purpose, but now the other thing you need to check, of course, you need to check the TSH, free T4, free T3, and then you check calcium level because the parathyroid hormone could be involved. Anti-thyroid globulin antibodies checked, and anti-thyroid peroxidase antibodies need to be checked, and of course you check the ESR and CRP, and of course you need the IgG4. Now remember, if the IgG level is greater than what? Greater than 1.35, the sensitivity is 90%. I'm almost like 98%, and the specificity is around 80%. Okay, so let's write it up here. Sensitivity 98%, specificity around 78%. Okay, so IgG4 level greater than 1.35. It's very, very important. Okay, now imaging studies, of course, you need to get the thyroid ultrasound. What will it? Diffuse hypoechoic, hypovascular appearance due to fibrosis, and then carotid artery encasement, also very common, is to differentiate from other diseases. And the CT scan, if you have like compressive symptom, you want to look at the other organs, important. How do you treat it? Steroid. That's the mainstay of treatment, okay? If they're not, like the other treatment we can try is tamoxifen and rituximab in the steroid resistant cases. And then what about the role of surgery? Not really, unless there's obstructive symptoms or like resistant to medication, then you can consider surgery, okay? So just look back on a whiteboard, find out what's going on, a brief summary like one more time. The definition is an infiltrative, inflammatory, fibrosclerotic condition, destruction of thyroid gland, compressive symptom, endocrine abnormalities, fibrosis going to the airways, parathyroid gland, and other local structures, okay? And remember the other term, woody thyroiditis. Females is more common. And look at the other associate conditions, very, very important. Okay, systemic fibrosis in 38%. Even autoimmune thyroiditis is common in these people. And then, if you have to examination purpose, retroperitoneal fibrosis associated with the RIEDEL thyroiditis, very, very important. Okay, and then it can affect a lot of organs like salivary gland, lymph node, all of that. Clinical presentation, look at the thyroid. You got the woody feeling, compressive symptoms, Tolosa-Hunt syndrome, you got cerebral venous thrombosis, hypothyroidism. Let's look at our pathophysiology one more time. What happens? You got the T, mainly we have to think is predominant response to T helper 2 cells, right? Then after that, you kind of think about this T regulatory cells because of that, and then TGF-beta, fibroblasts, fibrosis. That's the main pathology, fibrosis. Remember that, okay? And then you got eosinophil mast cells. And then you got this plasmablast activated B cell producing, plasma cells, IgG4. Again, number one for diagnostic criteria, right? And then biopsy finding also we need to know dense lymphocytic infiltrate, storiform type fibrosis, and obliterative phlebitis. Now let's look at our diagnostic criteria: mass greater than one organ, okay, and then serum IgG4 level greater than 1.35, sensitivity is 98%, specificity is 78%. Very, very important, okay? And then plasma cell lymphocytic invasion with a greater than 10 IgG4 positive plasma cells in the high power field. Diagnostic in the laboratory, none is diagnostic, but you have to check all the other lab, TSH, free T3, T4, calcium level because of the parathyroid hormone involvement, and then you got anti-thyroid globulin antibodies, anti-thyroid peroxidase antibodies, and ESR, CRP, IgG4 level. Think about the ultrasound and the carotid artery encasement in the ultrasound is also very diagnostic, and the treatment is prednisone, prednisone, prednisone. Thank you so much for watching. We'll be back with another presentation soon. Please help us subscribe to our channel. Thank you.